All right, let's get right into it. We are entering the world of advanced oncology. This is where every single decision is absolutely critical. And believe me, the stakes could not be higher. We're here to seal the logic gates on some of the toughest concepts you're ever going to face.
And that right there, that's the whole game. You have to get this into your head. In this field, we're walking a razor's edge. The therapies we use, they're powerful weapons. And they have a razor-thin margin for error. You misuse them, and the consequences are devastating. This is not a drill.
Now, real quick before we dive in, the mandatory disclaimer. Remember, everything we talk about here is for educational and exam prep purposes only. It is absolutely not medical advice. For any real-world clinical decisions, you always consult the official guidelines and a qualified specialist.
Okay, our first logic gate. I call this the transplant war. This is the brutal internal battle that can erupt after a bone marrow transplant, and you have to understand the mechanism inside and out because, well, it can be absolutely devastating. So, what is graft versus host disease, or GVHD? Fundamentally, it's an invasion. The brand new donated immune cells, that's the graft, look at the patient's own body, the host, and see it as a foreign enemy. So what do? They do what they're programmed to do, they attack. This isn't just some minor side effect. It's a life-threatening complication that keeps clinicians up at night. And this attack, it isn't random. This is what's so key. It has a classic hit list. The donor cells go after three main targets: the skin, which causes a rash, the liver, leading to jaundice, and the gut, which results in terrible diarrhea. Recognizing this triad, skin, liver, gut, and recognizing it early is absolutely critical for the patient's survival. This is a classic board question. You have to remember it.
Let's move to our next scenario. We're shifting gears to the pediatric ward. Here, we're faced with a diagnostic challenge that hinges on a single, critical dividing line. This is what I call midline logic, and getting it wrong, well, it has catastrophic consequences.
So here's the case. A 3-year-old kid comes in with a large abdominal mass. You can feel it. The intern's first instinct, probably your first instinct, is to get a piece of it, right? Order an immediate biopsy to see what it is. But is that the right move? Think about it for a second. A child's entire future is riding on this decision. No, absolutely not. That move is a catastrophe just waiting to happen. And why? Because you risk causing what's known as a seed disaster. Puncturing the wrong kind of tumor capsule can spill malignant cells all over the abdomen. You could instantly take a curable, localized cancer and make it advanced and infinitely harder to treat.
And this right here is the midline logic in action. The key, the dividing line, is the body's midline. A Wilms tumor, it's usually smooth, and it respects the midline. It stays on one side. That's the one you never biopsy before surgery for the exact reason we just talked about. But a neuroblastoma, that's different. It's irregular, it's firm, and it famously crosses the midline. You also look for calcifications on the scan and the classic dancing eyes and dancing feet of Opsoclonus-myoclonus syndrome. Know the border before you even think about touching the skin.
Now for the next big board exam trap, chemotherapy side effects. Look, it's not enough to just know the names of the drugs. You have to know the specific damage they cause, and more importantly, how you protect the patient. We're talking about toxicities that cause permanent damage or even force you to stop a life-saving treatment. This is the Chemo Shield.
This table is pure gold. You have to memorize these pairings. Doxorubicin, it shreds the heart muscle. You shield it with Dexrazoxane. Cyclophosphamide makes the bladder bleed. You protect it with Mesna. Vincristine attacks the nerves, causing a neuropathy that might never go away. And then the heavy hitters. Bleomycin scars the lungs, irreversible pulmonary fibrosis, while cisplatin is a double whammy, famously toxic to both the kidneys and the ears. You have to master these pairs: the drug, the toxicity, and the shield. It's how you keep the treatment from becoming the killer. Okay, time to lock all this in. We're going to run a rapid-fire drill, a staccato ping-pong, to make absolutely sure these concepts are sealed tight in your memory. Ready? Let's go.
Donor T cells are attacking the recipient. What is it?
GVHD. That's the graft waging war on the host.
A pediatric abdominal mass that crosses the midline?
Neuroblastoma, the one that ignores the border.
What's the key genetic syndrome tied to Wilms tumor?
WAGR syndrome, Wilms tumor, aniridia, genitourinary anomalies, and retardation. Locked in.
The classic, dreaded toxicity of bleomycin?
Pulmonary fibrosis.
irreversible scarring of the lungs.
And to finish it off, the 2-organ hit from cisplatin.
Nephrotoxicity and ototoxicity. You don't forget the kidneys and ears. Logic sealed.
You now have the foundational logic gates for high-stakes oncology. You've walked through the transplant war, the midline divider, and the chemical shields. But this is just the beginning. The real test is putting it all together under extreme pressure. If you can't run this entire decision tree in under a minute, you are not ready. Your training continues.